I would like to thank the organization for inviting me. I'm really honored to be here. I really like this meeting, and I really enjoy being here. I was asked to speak about patient safety issues in infectious disease, and actually I would like to start by a small historic perspective, because actually a lot of things about infectious diseases and risks are taken for granted in these days, and actually as it is like the EU, and sorry for mentioning this will be the last time I will mention it. There's so many good things that are so usual for us nowadays that we take them for granted and we forget how much hard work it was to establish them. So let's take a short historical perspective for infectious diseases. You see, where we came from in 1900, infectious diseases were in fact the most important cause of death. And for various reasons, I will show you, it came down to where it is now. So actually the main risks in infectious diseases have already been solved by our predecessors. You see the two peaks, this is the First World War and actually mainly the pandemic that came afterwards, and this is the Second World War. That obviously make a small temporary rise in infectious diseases. And actually it were people like this who solved most of the problems already. People like John Snow, the famous London physician who found out the causes of cholera in London in those days, and Semmelweis, who earlier on discovered that with better hygiene he could prevent infections in women at labor. So you see, this is just a nice graph that you see about that Semmelweis made based on his mortality rates in the Vienna General Hospitals. And you see that after he introduced in 1847 that everybody should wash their hands before they helped women, that the rates for mortality dropped dramatically in his wards. And here you see a nice map of that John Snow made, just counting all the cases of cholera in those streets in central London, and they were all, as you know, around a pump. That was actually the main cause and source of the cholera cases, and he found out that actually was the case, because before that they thought actually that it was the smell in the streets that was really pungent at those days was actually the cause of spreading the disease. And actually the pump is not there anymore, but as you might expect, there is a pub now on the same spot called the John Snow pub, really worth visiting, and there is on the pavement before there is a small memory for where the pump once was. And if you didn't read this book about John Snow and his work, you really should read it. It's called The Ghost Map. It's written by an American, but even so, it's a really good book. And you should really read it. I really enjoyed it. It reads like a thriller. And of course, going back to UK physicians, actually it's actually quite resembles the work of John Snow that William Pickles, of course, did in the 1920s and early 30s, where he also meticulously, after a busy day in the practice, actually sitting in his bed, he made these graphs just counting the infectious disease cases in the communities that he took care of, and by that he was able to detect the sources of these infectious diseases in the Yorkshire Dales. And of course, vaccination, to finish this historical perspective, also really paramount. And actually nowadays people forget how it was before we had vaccinations. Jenner, of course, at the end of the 18th century, discovered that when he inoculated this boy with the fluids of a milkmaid who had the cowpox, and he prevented this boy of getting smallpox. And actually, of course, many people explained to us that actually it was not the vaccinations and the antibiotics that helped us to get rid of the main infectious diseases. That partly is true, but actually Just a recent publications by Dutch public health experts show us that actually vaccinations did really matter, and this is the rise that again was in the Second World War. It came down afterwards, but actually there was a clear difference after the vaccinations were taken up in the Netherlands. Same with pertussis, and actually those infections gradually more or less disappeared. The mortality disappeared in our country. So vaccinations really did matter and do matter at this moment. So the current rates for complication in primary care infectious disease actually are quite rare at the moment. The incidence of pneumonia is around 5% in patients with acute cough. The 30-day mortality in elderly patients, that's the most high-risk group, is 3.5% if they have a pneumonia. Pyelonephritis, for instance, also quite a prominent complication, occurs only in 2 to 3% of urinary tract infections. And if you, well, one of the main causes of death 100 years ago, pertussis in children, actually is now actually virtually gone. I mean, only one in the Netherlands, only one infant death every 2 years now. So how are we going to deal with this? Because every GP here in this room have seen one of these complications, and sometimes you miss it and you don't want to miss it. So how are we going to deal with these safety risks in patients? They are rare, but they can be quite severe. They can have serious consequences for these patients. So first, of course, you want to optimize your diagnosis. You will optimize the treatment. And now, starting with diagnosis, actually, that is not a very easy task to get a correct diagnosis for disease who are severe, but are not very frequent. Now let's look at a few studies who actually tried to tackle this problem. The group around Van der Bruel and David Mant and others, they looked at how they could solve the problem of detecting serious infections in children. And they saw that, as you already suspected, only 1 to 3% of children presenting with signs and symptoms of infectious disease do have a serious infection. They found that these 4 characteristics actually did predict serious infections. Gut feeling from the physician, very important. Fever, high fever, dyspnea, and diarrhea in young infants was in fact predictive for serious disease. The sensitivity of these model was 100%, which is pretty good. Specificity was 65%. Now that seems actually not too bad, but if you look at the next table, you will see the problem. Because here I just graphed 1,000 theoretical patients, and with a incidence of a prevalence of 3% of serious infections, as you can see, a sensitivity of 100% and a specificity of 65%, and then you see what the problem is. I mean, you don't miss any infections, but in all the children with a positive model test, you see that only a very, very small minority does have a serious infection, and the vast majority that comes out and that you maybe do extra tests or you refer to hospital don't have a serious infection. So there's a vast overdiagnosis if you use this model, which is not good. Let's look at another side of the problem. Let's look at pneumonia, detecting pneumonia in adults. This is a European study that we did together also with UK colleagues like Paul Little and Chris Butler. We tested around 3,000 patients with acute cough. 5% of them had a pneumonia, 140. Now, actually, GPs did pretty well. If they thought a pneumonia was present, about 57% of them did have a pneumonia. That's pretty good, I think. But, and if they thought a pneumonia was absent, then around 95% in fact didn't have an infection. So that is, on first sight, not too bad. But if you look at it more closely, you see that the majority, the 2/3 of the pneumonias are in fact missed by the GP just by clinical assessment. So that is So what we did, we tried to improve that by developing a model, and the model you don't have to read it, but it's just a series of clinical characteristics like crackles and breathlessness, raised pulse, also CRP over 30%, and then we divided these patients into 3 groups: low, medium, and high risk groups. Well, in the low group, actually the model did something better than a GP, because 1.7%, that's better than the 5% negative predictive value that the 95% predictive negative value that the GP did. But if you look at the high risk group, so at maximum you will have a positive predictive value of 18%. That's much lower than the 57% that the GP himself was able to do. So the model will help you to a little bit to exclude pneumonia, but to actually detect pneumonia the model is not helpful. So clinical diagnosis physician is actually the best we have at the moment, as you saw, and diagnosis models might help a little bit at best. So how do we handle this diagnostic uncertainty? Well, of course, first we offer reconsultation. We inform patients about red flags. We offer delayed prescription. But actually the main strategy that we all have is that we just give them loads of antibiotics, whether they have a serious infection or not. And we just try to cover up by doing that. That's what we usually do. I'll just show you one slide, which is, I know it's data from 2005, but I can assure you, it's Dutch data that actually the last 10 years, we also have recent data, it didn't change very much. Now, on the right-hand side of the zero line, those are the patients who did get antibiotics, and on the left-hand side, those are the patients who didn't get antibiotics. So these are ear infections, upper respiratory tract infections, sinus, throat, pneumonia, bronchitis. And the orange and the red parts of the bar are not correct. So these is overprescriptions, the red parts, and the orange is underprescription. And actually what this study learned us is that we are a low prescribing country, the Netherlands, but actually per indication it differs quite hugely. Yeah? So actually, and there's also underprescription. In ear infections in the Netherlands, there are more children who missed out on getting a antibiotic treatment that, according to the guidelines, they needed than the overprescription was. For the other indications, there was much more overprescribing than underprescribing. Another interesting thing that we found out when we looked at antibiotic prescription in our country is that the huge variation. Of course, that is also what we know already, is that there are colleagues who prescribe quite a few antibiotics, but also colleagues who prescribe 5 times as much. And the same is, you see, for the choices of second choice antibiotics also, there are colleagues who actually are very low here, below the average, also physicians who prescribe a lot more second chance antibiotics. Let's look at the out-of-hours prescription, because that's also regarded as a source for risk for patients, because you have less time, you don't know the patients, and patients think they are seriously ill because otherwise they wouldn't come at the weekend or during the evenings. Now you can see here, the figures are quite reassuring as far as out-of-hours services, at least in the Netherlands. First of all, you see that actually the proportion of antibiotics prescribed during out-of-hours compared to the daycare is quite a small proportion. So that is absolutely, it's not a very big problem. And if you look at the next slide, actually what's surprising for us is that you see here that the light blue is the overprescription. We compare it with guidelines, again, like the last slide. And you see here, this is overprescription rates are mounted here on the top bars for otitis media, sinusitis, etc. And you see only for otitis media, the overprescription during out-of-hours is higher than during the daytime, which is only 4% you see here on this graph. But for the rest of the infections, actually, the overprescribing was less during out-of-hours than in the daytime. So our conclusion was here that overprescribing is present there, but it's not a bigger problem than during the daytime, which is reassuring. Another thing that you should keep in mind, I really like this study. That was done also in this European study that we did together. Nick Francis from Cardiff, who was the first author. Actually, that was quite shocking that we prescribe far too many antibiotics, but the patients, they protect themselves more or less because in these 12 European countries where we did the study, only there was 40% of these patients didn't take the antibiotic, which is quite high. And even in a country like the Netherlands, it was 30%. So 1 in 3 prescriptions that we Dutch GPs prescribe, they will take it away, they think thank you very much, and they won't take it. So it's really interesting. Right, now is this overprescribing, does it serve a cause? Does it in fact, is it helping where we actually wanted it to be helped at avoiding serious cases? Yes, it does to some extent. This is a very nice study from Peterson and colleagues in BMJ 2009, showing you the relation between infections given for these infections, like so upper respiratory tract infection, otitis media, and then you see how much cases of serious complications of these infections were avoided. And actually what you see is that, yes, it avoids serious complications, but the number needed to treat is over 4,000 for 3 of the 4 infections. So in fact, you really have to treat more than 4,000 patients to avoid 1 complication. For chest infections and pneumonia, it's slightly lower. Yeah, it's even for people over 65, it's 40 cases. So if you have to treat 40 elderly to prevent 1 case, even that I think is not a reason to prescribe for all these coughing elderly, but that's for the debate. And just last week, another really nice study came out. I explained this graph to you, don't worry. This was published by Gulliford and all English colleagues last week in the BMJ. Really worth reading because it's really interesting. It shows you the relation between high and low prescribing practices and the number of cases of severe infections that they saw in their practices. And you see for pneumonia and peritonsillar abscess that there is a clear relation. You see the less they prescribed, the more cases they saw, or the other way around, the more they prescribed, the less cases of pneumonia they saw, and again with peritonsillar abscess. For the rest of the serious infections, actually, there was maybe a trend, for instance, for meningitis, but it was not statistically significant. Those infections are so rare that a relation could not be established. Although there is a relation, the relation is such that they also calculated that an average UK practice of 7,000 patients, if they reduce their prescription rates with 10%, they would see 1 case of pneumonia less per year. And they also would see 1 case of quinsy every 10 years more. So that is, and 1 case of pneumonia per year more. If they were to reduce their prescription rates with 10%. So actually that there is a relation, but the relation is not very worrying. It's not a reason not to reduce antibiotic use. There are also other safety issues related to antibiotic prescribing, of course. The side effects assumed to be around 10%. There is medicalization. There's a clear relation between antibiotic prescription rates and reconsultation. I put allergy between brackets because that is actually largely overrated. We found also in a study that we did that 85% of the patients with a label of allergy in our don't have an allergy, in fact. They have a label, but it could not be confirmed by intensive testing. And there is, of course, a relation between antibiotic use and bacterial resistance, as you know. Just to show you this graph, that there is a clear relation. Of course, lower prescribing countries have lower resistance rates, as is on the y-axis. Higher prescribing countries, of course, have higher resistance rates. So there is a clear relation between resistance and antibiotic use. And so we could those are actually all good reasons to actually try to reduce antibiotic use. Many studies have shown that that is really possible. I just showed you one of the key studies that have been done. Again, a EU collaborative study. Paul Little being the first author and the leader of this study, published in The Lancet 2 years ago, where we actually did a trial where we compared controls with intervention of communication skills, offered by a web-based module. Also, we offered CRP testing to them, and also a combination. And actually, you saw, as you can see, that the combination after the first year showed the biggest effect, 22% less antibiotic use, which is quite impressive. Also interesting is that we did this in 6 countries, Wales, England, Belgium, the Netherlands, Spain and Poland, and in all of these 6 European countries the effect was more or less the same. That was quite surprising. And also surprising to us was that after 12 months the effects of communication training persisted, but the effects of the CRP testing was not there anymore. So, well, it's just... Okay, antibiotic resistance, of course, should be monitored. In most northern European countries, that is done. You see here in low-prescribing countries like the Netherlands, antibiotic resistance rates are still low, although for E. coli, for instance, there is relevant resistance rates, and we actually adapt our prescribing guidelines according to that. And as you can see, we do this is over the last 5 years, the resistance for E. coli. You see that it's actually quite stable. It's not a big worry at the moment, resistance in a low-prescribing country like the Netherlands. All right, so the conclusion. The conclusion is that we can't avoid all the risks there are in infectious diseases. There are risks, the risks are not high, but we have to accept them. And actually, every GP in this room did miss a serious infection if she worked in the practice for more than 1 or 2 years. We all have examples. I sat last night I sat at a table and we talked about this, and actually everybody around the table had examples in his own practice. We need, so the diagnosis, I think we should accept a risk that we will miss it. Treatment, of course, rational antibiotic use and patient information is very important. Evidence-based prevention, I just told you about. But again, we have to accept that we will miss some infections. And we have to talk about those incidents. We have to sit down and be open about it, because you're not the only one who makes mistakes. And if you talk about it, if you think about it, what did I do wrong? Maybe you didn't do anything wrong, but maybe you can learn from it. And loads of antibiotics will only make it worse. All right. And this is just a graph that I really like as well, because it shows you that in the standard and routine parts of our care, quality systems and guidelines and protocols help us, and the evidence we produce will help us to make them better. But you also have the non-routine. Of course, every patient is different, and there is, of course, patients where guidelines do not apply and where more uncertainty is there, and their guidelines won't help you that much. You have to rely on your experience, on your clinical intuition, also on the advice of your colleagues. So it is, of course, evidence-based medicine is important, but you have to accept also levels of uncertainty, and you have to rely on your clinical assessment much often. Now, I've told you about how we deal with safety risks in infectious diseases in Northern Europe. There is, however, one thing that can't be, we have to speak about that as well. And I think I just remembered you where we came from. Actually, there is a situation where actually which reminds us where we came from, and which actually where people actually are exposed to much higher risks that we see in our common practice. Cholera is already present in camps that are not very far from Europe. And in the camps that we have quite near, there's bad sanitation, lack of healthy food, and a lot of stress. This is just a photograph of the camp in Calais. And you can keep people there for 1 week, 1 month, 1 year, 2 years. But everybody will see that these people will be at risk for all kinds of health risks and also infectious disease health risks. And I think and I hope that the European Communion, despite what some politicians say about refugees, will stand up and have the courage and the compassion to help these people. And I think we have, as doctors, have a role in that. Thank you very much.
Thank you very much indeed, Theo, for that outstanding talk. So we're open to questions now. If people wanted to ask questions, could they come to the microphones? We have 3 microphones there, and introduce yourselves at the outset as well. So we have a question already from the middle.
Frances Mayer from Glasgow. Thank you for that really good overview. It's really a question of fact. You showed that slide that showed the patients, only 40% of them actually taking the prescription.
Yes.
Do you know if that was because they had been told to have delayed prescribing, so a GP had maybe said, here's a prescription, but only take it if you get worse, or do you know the circumstances around that?
No, it's not. Actually, there's not many countries where delayed prescribing is taken up so good as in the UK. So most countries, it was just ordinary prescriptions. It was actually the uptake was 60%. 40% was non-compliant. That was it. And actually, it was in the high prescribing countries, non-compliance was much higher than in the low prescribing countries.
Okay, thanks.
Over on our left.
I wonder if we know whether bacteriological testing, for example, throat swabs or sputum culture, makes a significant difference to both overprescribing and to the risk of missing, at least initially, serious illness.
Yes. Well, first of all, not all bacterial infections need treatment. That's one thing.
Sure.
And the other is that we have the problem of carriage. There are a lot of children, for instance, 30% of the children are carriers, and around 10% of the adults are carriers as well. So, and there are not many tests who are reliable detecting bacterial infection. There are a few who help us a little bit, but for instance, the studies from Paul Little about testing bacterial infections in throat swabs showed us that it was not very helpful, actually, because the test was not perfect, there was carriership, and not every bacterial infection needs an antibiotic. So, on the whole, I don't think that is a very fruitful opportunity for us at the moment.
Thank you.
Bruce Arroll, Auckland, New Zealand. About 10 years ago, a colleague told me a revelation that we make up the duration of antibiotics that we give patients, either 3, 5, 7, so odd numbers up until you get to 10, and then it's 10, 12, 14. And there's a bit of a movement in New Zealand to look at shorter courses of antibiotics, yes, particularly when people don't need them. The smaller load. I just wonder if you have a view on that.
Well, there's surprisingly little research on the optimal dose and the optimal duration of antibiotic treatments. I think if you think somebody doesn't need a treatment, you shouldn't every day that you give them antibiotics is too much. So right. I think patient information and explaining to them actually can be successful. Even in a country like US, for instance, it was shown that people actually that their first need is not an antibiotic, but it's just proper examination and explanation. So I think that's the answer.
We're even looking at skin infections for shorter courses. So, where an antibiotic probably is indicated, that the shorter courses may be as good as longer courses.
Sure. Yeah.
Theo, can I just ask on that? If reducing the courses, and obviously it's a good idea, but the impact on resistance, I mean, after 5 days, has the contribution to increased resistance been made? And it's a good idea to reduce, but we can't expect any change in resistance patterns. Is that known?
Well, what I know is actually there's no relation between the duration of the treatment and the antibiotic resistance development. Whether 1 day or 2 days really makes a difference, I don't know. It could be actually what we see now is actually the amount of antibiotics that we give per year in a population is clearly related to antibiotic and resistance rates. whether actually short or longer courses have a higher impact, I'm not sure.
Theo, Paul Little for those who don't know me. Not surprisingly, I love the talk. Just the bit about the Nick Francis study, the two big cohorts, pretty much national cohorts we've done for sore throats and chest infections, people who are given antibiotics do take them much higher than, so I wonder whether there's an artifact there.
Yeah, could be.
So that's the bad news. I don't think we can assume that people aren't taking antibiotics when we give them, by and large. But the bit of good news that I think could come out of the missed pneumonia, I mean, obviously we don't want to miss pneumonia, but it looks like that the people that we miss, that we think don't have clinical pneumonia, in fact have a milder illness, they would probably benefit from antibiotics a bit, but they're probably not going to come to terrible harm.
Yes, well, it's you're perfectly true. You're right. Milder pneumonias, if you miss them, John McFarlane already showed that in his studies in Nottingham, is not a major problem. But also we showed, of course, that if we treat missed pneumonias, actually it makes a difference of around 5 days of symptoms,
symptomatic.
so,
But if you're worried about something horrible happening,
no,
you don't need to worry about something horrible happening.
On our left.
I wondered if you might talk about prognosis in infections and whether you think that might help us, given that we can't necessarily diagnose illnesses which are in a rapid phase of sort of evolution and are perhaps going to develop, but we don't yet know at the time when we see them.
Yes, well, actually there are not many studies who are so large that we can't actually look at prognosis. Actually, yesterday I just listened to a talk that actually was big enough to show some more relevant prognostic models. But again, the complication was so rare that you might wonder whether you could use these prognostic models in daily care. But maybe you yourself, as one of those researchers in the project, could tell more about that. Do you think that the things you found in the 3C study were helpful there?
So I wasn't part of the 3C study, but we have a study that we think can predict future events for children who've presented with respiratory infections, which we hope will be published soon. And I think it may help, particularly in ruling out. There is the similarity with 3C, that I don't think we're going to be able to particularly confidently rule in, but I think we will be able to increase our confidence that we can rule out. And because a lot of prescribing, we know, occurs because people are concerned about what might happen, and they don't want to be seen to look to have undertreated somebody who subsequently gets worse. Then if we can improve our confidence in the groups that we know have got very low risks, that may prove useful.
Yeah, but ruling out is always a bit worrying in a population where the pre-test probability of the problem that you try to detect is already so bloody low. I mean, if the incidence of serious complications is lower than 3%, your model has to be very, very good to help you further to reduce that 3%.
Although I think the statistics suggest that ruling out is still going to be better than ruling in.
Yeah, sure.
Although you're right, the rates are very low. As your data has shown, we still are significantly overprescribing to try and cover ourselves for that very low rate.
Yeah, yeah.
Over on our right.
Yeah, thanks, Theo. Tony Kendrick from Southampton. I know, obviously, from working closely with Paul and you and Mike and colleagues that delayed prescribing of antibiotics is not associated with any greater risk and actually helps reduce antibiotic prescribing overall. But there's a lot of ignorance and a lot of resistance amongst GP colleagues generally, which was brought home to me in the recent NICE Indicator Committee. I'm a member of the National NICE Indicator Committee, which produces indicators for the QOF. You'll be aware of our QOF, which we still have at the moment in England, although it's gone in Scotland and it may go in England soon. And we had a discussion about incentivizing delayed prescribing on the back of a NICE guideline that Paul and others led, showing that it's evidence-based. And the non-academic GPs in the room are saying, oh, I don't do this, I think it's dangerous, patients don't like it, you have to spend ages explaining it to them. And I had to get really quite assertive, which is unusual for me, to push it through, and it is going to be piloted as an indicator. But it's interesting that despite an awful lot of evidence collected over the last 18 years by Paul and yourself and colleagues, the message is not really getting out there, and it still needs promoting and possibly rewarding.
Yes, well, very interesting point you raised, because actually I don't use delayed prescribing myself. And actually, I also always have the feeling it's also a little bit of a cultural thing.
You don't use it?
We in the Netherlands, well, let me explain. In the Netherlands, what we actually think about delayed prescribing is, well, you give delayed prescribing to people that actually you think don't need antibiotics. Maybe they would need in the next 3 or 4 days. So what we prefer to tell to these people is, well, I don't think you need an antibiotic, but please come back if it doesn't get better. And if you get worse, and we'll tell the symptoms that they should be looking out for. And that's actually what we prefer in the Netherlands. So actually it's not really delayed prescribing, where we offer them reconsultation in the next few days.
It may be easier to get reconsultation in the Netherlands. It's getting harder and harder here.
Yeah, well, that's actually true, because usually if somebody rings our center, he can come the next day or the same day even. That's not a problem at all. So that's actually a condition that needs to be there in order to do that. I fully agree with that.
It does emphasise the importance of health systems. So in Ireland, where we are at the moment, where 2/3 of patients have to pay to see their doctor, if you don't give a prescription, there's pressure perceived or otherwise, and that, you know, I paid the doctor €50 and he didn't even give me a prescription, and he expects me to pay back. So certainly delayed prescriptions are, I think, reasonably common in Ireland. I do think there's an age effect, that the younger doctors are very comfortable in using their communication skills to utilise them. I think perhaps as one goes on in experience, you do see the cases that you've talked about, and even though it might be 1 in 4,000, one is left with that legacy, I guess. Uncomfortable prescribing decisions coming up?
No, not really. Colin Bradley, University College Cork. I was actually going to tell you about a little study and a little anecdote, but Andrew just reminded me, so now you're going to get 2 anecdotes.
That was a very bad idea of mine. So
I'll start with the first anecdote. I worked in a practice once where they had an arrangement whereby patients could leave their prescription in a box in the practice, and it would be picked up by a pharmacist and delivered to them by the pharmacy. And this practice were also keen on delayed prescriptions until they discovered that all the prescriptions that they gave to the patient with delay went into the box anyway. So, so that was sort of saying the patient wanted to get the antibiotic. Interestingly, related to that, there was a study we did then a few years ago looking at what people did when they did get these prescriptions for antibiotics. And it goes back to the issue of non-adherence that you mentioned, which I think was helpful to bring up, because I think it is an issue. And we did a little study again on adherence to antibiotic prescriptions a few years ago. And what we found in the Irish population anyway was that the strongest predictor of non-adherence was actually the day of the week. The patients don't take antibiotics on the weekend in Ireland. So if we give an antibiotic prescription, if we give a prescription for an antibiotic on a Thursday, it won't be taken till Monday, if taken at all. If we give a prescription for an antibiotic on a Monday, it will be taken up until Thursday. It stops on Thursday, because then they have to have their weekend break from antibiotics. I don't know what else they're taking, but we have an idea. Finally, the other little anecdote, just a little, again, to reinforce this issue about non-adherence. And as you say, we've all had this situation of the complication of infection. I had a patient recently who developed a very nasty empyema, and that was very sort of upsetting in some ways, although, in fact, in his case, I had detected the pneumonia earlier in the week, and I had given him a prescription for an antibiotic, but he hadn't taken it.
Just to comment on the delayed prescription discussion. So the big cohorts we've done now show that if your initial prescribing strategy is not to prescribe, despite safety netting, you'll have higher complication rates. So I think the utility of delayed prescribing, which is not well done in routine practice, because the right advice about the number of days you need to delay is generally clearly not given. But on the other hand, if you are thinking that there might be a problem, a delayed prescription will work as effectively as an immediate antibiotic in preventing complications. We know that from 2 big cohorts now. But the most important thing for routine practice, where GPs are on their knees at the moment, is that if you don't prescribe an antibiotic, even though they have less severe clinical features, 20% of them will come back over the next month in the UK anyway. And you'll reduce that by 1/3 if you give a delayed prescription. So even if you had no effect on immediate antibiotics, which we know you do, you'll have an effect on reconsultation. So it has a place. It shouldn't be used most of the time. Most people don't need an antibiotic at all. But if you're thinking about an antibiotic, I think we now have evidence in 2 big cohorts. It's probably sensible to give a delayed prescription.
Okay.
Thank you very much. So just like to thank everybody for their participation here this morning. I think we'll all agree that we really had an outstanding overview from Theo. Certainly a pleasure for me attending the SAPC is just to see the quality of work. We've moved now to such high quality evidence in this field provided by Theo, Paul and others. Cohorts of 20,000 people to me are just amazing to see. A really high quality work, and Theo delivered all that plus an ethical challenge to us as well, I think, on the asylum seekers. And again, faith in the young in Galway, small community of general practitioners. 2 of the younger GPs are MSF doctors who go out on rotation to the asylum seeker camps and are currently fundraising through the GP community there. So I think we can have faith in the young, hopefully, to deliver on those challenges. Many thanks indeed to you all.